Assalamu alaikum. Good evening, dear professors. Good evening, dear colleagues. I'm going to talk about two case scenarios in neurometabolic disease. Case number 1. Male patient, 14 days, third order of birth, first cousin consanguineous parents, presented to us with hypoactivity and poor suckling. The condition started at age of 10 days with hypoactivity and poor suckling, sought medical advice and admitted in neonatal ICU. Many investigations were done, but the significant one, CT brain showed hypodense white matter, extended metabolic screen showed elevated leucine, isoleucine, and valine, diagnosed as MSUD, then referred to us. His past history, he was full-term cesarean section, NICU admission for 7 days after birth due to poor suckling. Family history, positive similar condition as his brother died at the age of 4 months due to chest infection, and he was diagnosed MACD also. Examination on admission, he had poor general condition, chest clear, heart normal, abdomen lax with no organomegaly. Neurological examination, Glasgow scale was 13 and he was hypotonic and hyporeflexic. Investigations on admission, CBC was normal except mild anemia. Kidney function and electrolytes were normal. EPG, pH 7.45, PCO2 41, and the bicarbonate was 28. Case progression. The baby was admitted in pediatric ICU on IV fluids and single antibiotics, and Mahoka was inserted to start hemodialysis as due to his high level of leucine and isoleucine that was more than 5,000. First session of hemodialysis was started. Follow-up metabolic screen, still high level of leucine and isoleucine, 1,700. So the second session of hemodialysis started again. After the second session of hemodialysis, the baby became disturbed, so CT brain was done, showed diffuse brain edema. Hib labs, sodium 133, potassium 3.9, calcium 8.5, and random blood sugar was 91. And the patient had regular breathing, so intubated and ventilated, and brain dehydrating measures started. Follow-up metabolic screen, leucine and isoleucine level was 900, so no hemodialysis. The third session not done at this level. Patient remained on brain dehydrating measures, improving conscious level, and follow-up CT brain involving brain edema, and then patient started to take spontaneous breathing, so extubated. Follow-up metabolic screen, isoleucine level was 1,700. So the third session of hemodialysis started again. Patient kept on brain dehydrating measures and his conscious level improved. He has good suckling, good activity, good reflexes, and start oral feeding with MACD formula. We continue the formula, MACD formula, and the brain dehydrating measures stopped, and the baby is charged to the genetic department. Case number 2. Female patient, 10 years, first cousin consanguineous parents, presented to us with bilious vomiting for 4 days and disturbed conscious level. The condition started with bilious vomiting of 4 days, duration of sudden onset, progressive course 4 times per day, not responding to antiemetics, and high-grade fever, not responding to antipyretics. Then the child developed disturbed conscious level. Sought medical advice and admitted on IV fluid and antiemetics without improvement, so referred it to us and admitted to PIC. This female has multiple hospital admissions. She had NICU admission for 4 days due to refusal oral intake, increased sleepiness, and jaundice. Multiple admissions due to recurrent attack of fever, vomiting, started the first admission after NICU at age of 1 year. At age of 3 years, patient started to develop loss of consciousness, loss of hair, fever, disturbed conscious level. Many investigations were done, but the significant one was urinary organic acid and diagnosed as isovaleric acidemia. Her family history: first cousin consanguineous parents, no similar condition. Examination on admission: bad general condition. She was pale, drowsy. Vital signs: heart rate 100, blood pressure 90/60, temperature 37, respiratory rate 20, saturation 95, chest clear, abdomen distended and tender, heart was normal. Neurologically, Glasgow scale 10, and she was hypotonic and hyporeflexic. Initial investigation: CBC was normal except mild anemia, and her arterial blood gases showed metabolic acidosis, pH 7.3, bicarbonate 17. Random blood sugar was normal, ESR 15, and CRP was negative. Electrolytes was normal, kidney and liver function was normal. Ammonia 130, lactate 14, and lipase 69. Extended metabolic screen showed high C5 carnitine, and urinary organic acid showed massive amount of isovaleric glycine, which is consistent with isovaleric acidemia. X-ray abdomen erect and supine was normal, as she has bilious vomiting and abdominal pain. Pelvic abdominal ultrasound showed minimal renal pelvic fullness, mostly due to urinary bladder fullness and mild ascites. CT brain showed bilateral symmetrical flu calcified foci on both corona radiata, and her upper GI showed mild gastritis. MRI brain was normal. Case progression: patient admitted in ICU on IV fluid, on high caloric intake, 100 kilocalories per kg per day, proton pump inhibitor, L-carnitine, glycine, and sodium benzoate. Pediatric surgery consultation: recommend conservative treatment and no rule for surgery. Genetic consultation: keep the patient MBO and on 1.5 full maintenance, IV fluids. TBN, intralipid 2 gram per kg per day, GIR 12. Stop protein for 24 hours and start sodium benzoate على 250 ml per kg per day, glycine and L-carnitine. Patient remain on TBN and keep MBO, no more bilious vomiting. GI consultation: recommend keep patient MBO and withdraw lipase and amylase, and was normal. 48 hours later, the patient regained his normal conscious level, no more bilious vomiting, abdomen was lax and passing stool. Follow-up: ammonia decreased from 133 to 55, so we start leucine-free formula. Patient became fully conscious, oriented, and tolerate feeding with leucine-free formula, no vomiting, no abdominal pain, and discharged to genetic department. Thank you.
شكرا جزيلا دكتور مصطفى. كنت عايزه اسالك، هي الحاله كانت ماشيه على اي علاج على انها هرمون؟ لا هي كانت ماشيه على فورمولا عشان الايزوفاليريك قبل ما تخش المستشفى ولا مش؟
كانت على الفورمولا. لا كانت على الفورمولا بتاعتها، بس هي
امال ايه اللي حصل؟
هي موستلي كانت في انفكشن، يعني هو دخلت دي كومبنسيشن لما يعني صلحنا الانفكشن وخدناها MBO، لان هي كانت متحوله على انها intestinal obstruction وتتفتح، بس احنا خلينا العينه MBO لما حسينا دي كومبنسيشن وقفنا البروتين الدنيا اتحسنت بعد كده، بس هي ما اتفتحتش، هي مبعوثه على انها intestinal obstruction وان هي تتفتح يعني.
شكرا جزيلا وويلكم باك. دلوقتي طبعا يسعدني